Good morning again. Really delighted to have a chance to pull you into second year in medical school class and discuss the background, if you will, of taking care of this public health problem. I thought this depiction is really indicative of many trauma centers around the United States and, for that matter, really around the globe, where firearm injuries and other injuries are being taken care of in emergency departments. Just take a seat, Mr. Byrne. You're acting as if you're the only one who's been shot. This headline in the Milwaukee newspaper over 20 years ago, I think, really pulls in what we have been describing here at this forum and many conferences in the past, and I'm sure in the future, where an epidemic pulls in public health, pulls in those sciences that we know inform other epidemics. And I thought this was a very significant change for us in the Milwaukee community to think about this disease process in a bit of a different way and frame it in a way that can get our hands around it and begin to be more deliberate about the ways in which we can manage it and prevent it. This is a classic gunshot wound, entrance wound. It's got a margin around the edges that are very classic for an entrance wound. It's very helpful for us to know that because it informs us as to where the bullet might be if it's still penetrated but did not perforate the victim. This is an entrance wound, close range of a shotgun. We know that that's important for us to know because there may be fragments of the shell inside the wound for us to be exploring and removing. And the reason why I'm presenting this initially is for us to think about how we've progressed in medical care and how we've been informed by the disease model that is part and parcel of our training in medical school and nursing schools, and helps us, again, shape our approaches to this disease. And the disease model is important because, again, it frames our thinking, it positions our strategies in a way that's based on science, and it's advanced based on that science. And as I went to page 4 of the pathophysiology text that's used in medical schools across the country, the disease model has fortunately changed. Disease was thought to be one's own fault. Perhaps you sinned. Perhaps you're with other people that you shouldn't be with. That there were bad smells, miasma, bad air, the cold, evil spirits. Maybe you're not part of the right religion, and that's why you're falling ill. This was and continued well into the 19th century to be the disease model that informed communities about how to manage primarily infectious diseases. Malaria is Italian for bad air, and well into the 1800s, it was thought that it was bad air that was the source of malaria. So we've come a long ways from this older view of framing those issues, those problems that affect humans, and really change into something more scientifically driven and really helps us to frame how we want to attack these diseases that afflict human populations. And again, in page 11 of this same text, it's a pretty big text. It just gets medical students crazy because there's so much that we're asked to assimilate, that the causes of cellular injury, which result in organ dysfunction, which result in cardiovascular collapse and death, can be divided into agents of disease. And the one that we have referenced here in yesterday's discussions, biological agents such as Ebola, such as malaria. And we have chemical agents. We referenced one yesterday, pesticides, which result in injury to cells when ingested. We have physical agents, kinetic energy being the primary one that we have been discussing. That is the causative agent that results in cellular damage, organ dysfunction, cardiovascular collapse, and death. And we have other areas of other segments, if you will, of agents that also result in cellular injury, immune reactions, genetic derangements, and nutritional imbalances. So for our discussion in violence, it's primarily driven by physical agents and chemical agents. We did a study on youth violent deaths in Wisconsin several years ago. 3 years of deaths, over 500 deaths were linked. Homicides and suicides were the division, and we looked at firearm and non-firearm causes of those deaths. We see that with the firearm deaths accounting for the majority in both of these sections, it's natural for us to start going towards the agent of disease that causes those deaths, kinetic energy, from the bullet carried from the gun. So it's natural for us to think about, at least as a physician, to start thinking about managing that kinetic energy if you can, or preventing that kinetic energy from reaching the individual. So this, in my view, is a lead kinetic energy infiltrate. You see the bullet there on the left side of the chest. Look at pneumococcal pneumonia. This is kinetic energy infiltrate. Kinetic energy pneumonia, if you will. For us to understand treatment, we understand that kinetic energy exchange has implications. You see with this interchange of the bullet striking the bone, the bullet is fragmented, suggesting that the energy release not only was transferred back to the bullet, it shattered, but also has implications for this bone that is absorbing the energy. We didn't diagnose the occult fracture. We missed it. So understanding this kinetic energy exchange and its implications helps us improve our treatment measures. Understanding this penetrating injury exchange, this kinetic energy exchange, helps us, again, to better inform our treatment strategies. Leave the knife in, because if you remove it too soon, it removes the tamponade that the knife has provided, and bleeding occurs and the patient may die. We keep the knife in until they're in the operating room safely so that it's removed under controlled conditions. Again, from the understanding of this as a disease model, it improves our treatment strategies. This is the CAT scan, a liver. This is the permanent cavity of a bullet going across the liver. By understanding the dynamics of this event, the surgeons have elected not to intervene, not to operate. Asking a trauma surgeon not to operate is an extremely important act. Not operating is an act, and it helps non-surgical, non-operative interventions are becoming more and more common because our ability to understand this dynamics is getting better and better. In understanding this trajectory, the entrance and exit wounds, it helps us to be more, if you will, informed in a forensic manner. We've had youth come to us saying, I was shot by somebody across the street. When we see the entrance and exit wound, you can barely see the exit wound here, suggesting that the bullet actually was discharged as they're taking it out of their pocket. And it helps us to understand this so that we don't request the police for inappropriate searches for assailants when in fact the individual shot him or herself. This is actually a police officer who shot herself as she was disengaging her Glock. This Glock has a very, very light trigger pull, and it's been a common issue of police officers. So the way I think it's beneficial for us is to frame this as a disease. These are the viruses, if you will, infecting our patients. These are the shapes, these are the sizes, and this is the energy differential from 22 to 44 magnums, inflicting predictably different levels of injury. And these particular bullets, black talon, inflict additional injury. There's a hollow point, and it opens up inside the victim. It causes additional injury to the cellular structures. And it's intended to do that, to also not perforate through the victim and harm somebody else nearby. Law enforcement felt this was an additional benefit for having this kind of a bullet as use for their use in show of force. And these are what I describe as the vehicles. Just like an infectious disease, these are the vehicles that carry this disease, this kinetic energy. So a number of years ago, we thought that it was really important to better understand this, because when you have a kinetic energy exposure, it's location, location, location. Where did you get shot? In the chest, in the abdomen, in the head, which dictates your outcomes. Where were you shot? Were you in a rural area, isolated, self-inflicted, as we saw yesterday, high case fatality ratio? And location, where will you get treated? Will you get treated in a trauma center that's has experience in treating gunshot wounds, or in places where they don't have that experience? So the location of where you're shot has got huge implications for outcomes. There's an interesting study several years ago in Philadelphia demonstrating that if you're shot with a 9mm, you're more likely to die on the streets. And a 22mm, if you're going to die, you'll be dying in the hospital. That energy exchange has differential implications. The challenge of this disease is that the pathophysiology lasts about less than a tenth of a second. There's not much opportunity for us to intervene like we do with other diseases. We can intervene during the infection, during the process of cancer development. In this disease, it's over, and we're now in the post-event phase of treatment. And our understanding of this really has been limited. Dr. Fackler and his colleagues did the early work of looking at the dynamics of a bullet going through simulated materials, mainly with military weapons. Never had there been a civilian examination of the bullets found in homicide and suicide victims. So a number of years ago, we went to the lab for this disease. And the lab for this disease is actually the crime lab. And the crime lab in Milwaukee we set up a dynamic simulation study using the technologies for examining car crashes. You think of the kinetic energy in a car crash, it lasts less than a tenth of a second. We take this high-speed video and technology and see if we can examine how the dynamics of a bullet are in simulated materials, low caliber and high caliber. This being the simulated material that is akin to muscle tissue. We had a laser beam in the front. The gun is discharged, the bullet hits the laser, trips the technology, and we recorded for the first time civilian bullets, not military, to better understand this disease process. Can you?
focus on a speeding bullet.
I assume you all know where that came from. There's the bullet being transferring through the medium. Over here is the time. There's the temporary cavity, and this is the permanent cavity being formed. And it's being formed over the course of hundreds of seconds. You think about the technology to be able to record this, it's only been recently developed to, again, better understand car crash dynamics. Now we understand a little bit better the dynamics of a bullet going through tissue. You can see the formation of the permanent cavity. Look at this. This is now not even a tenth of a second. This happens very quickly. And the next dynamic you'll see is a larger caliber black talon 9mm. You can see readily the differences between the two and the implications for patients. Now watch this. This dynamic was never been seen before, and we felt this was helpful for us to inform our medical practices. We can advance it. So if we look at these violence categories, the one that the disease etiology, the agent of disease that is the common component is kinetic energy, which is why we naturally want to look at the carriers of that, the firearm. So means do matter. We felt, and we've examined how understanding that the means helps us take care of patients, but also has other implications. So I want to end this brief introduction, if you will, to the pathophysiology of this disease by refreshing individuals about Haddon's 10 strategies, 10 countermeasures, which he published in the early 1970s. And the third strategy is where I think it's an area which we need to be thinking about, is preventing the release of the energy. Given how quickly this energy is transmitted and how it's late then for us to be able to intervene during that energy transmission. Unlike car crashes where we're intervening with seat belts and airbags during the energy transmission, we don't have that with firearms and bullets. So the strategy is to prevent the release of the energy, and we've discussed those as of yesterday. Bridges with safety nets or fences, as Lanny Berman described in the afternoon. We're going to hear about smart guns, child-proof containers. They can't access the energy, in this case, chemical energy. And even it was referenced by Dr. Haddon in his article that parapets on your roof and balcony were actually referenced in the Bible as a way to make sure your house doesn't have the blood of neighbors or family members. So we've made a lot of progress in taking care of patients who have been injured by kinetic energy. And Jim Mercy made a reference to an article suggesting that we've had some influence on homicide rates. We've had not much influence on firearm-related suicides because the pathophysiology suggests that it's too late for us to intervene. So as a physician taking care of patients, the best strategy for this kinetic energy released by a firearm is to prevent the release of the energy. Because by the time it gets to us, if it's in the head, if it's in the chest, it's probably too late. If they do arrive alive, we're pretty good. But we know that from those case fatality ratios, they're dead at the scene. It's too late. So the strategy, I think, in this disease process is preventing its release. And I think that's the end point I wanted to make as part of the improvements of medical care, is that we're reaching an end point where this is the strategy that makes the most sense. So I'll stop there, and we'll get to the next panelist. Thank you.